My name is Rihanna, and I want you to see me and see NF.
My name is Blake, and I want you to see me and see NF.
My name is Deshaun. I want you to see me and see NF.
People who have NF are so varied in different types.
I basically tell them it's genetic disorder, can cause tumors to grow anywhere on or in the body, and it's like something that you're born with.
I look healthy on the outside, but on the inside I have over 100 tumors in my body.
But what people don't see with my diagnosis is that I'm losing my hearing.
They just see this person, oh, you're really in pain every day?
I have NF1. I'm the only person I family that has NF.
They make assumptions that they're not just like every other teenager.
Because some people are different than other people. Might see you as someone who's different, but actually understands you and know it's a part of understanding what you're going through.
All of my tumors are internal. I don't have any skin tumors.
One of the things people can't see about NF is the constant worry we have, knowing that a tumor could be growing anywhere in their body at any time.
I'm not too sure. I might develop tumors, I might not.
I think about the future and I get scared, but then I meet people within CTF and the NF community, and it's inspiring.
Just because I have NF2 and I've had 27 surgeries, despite these challenges, I'm still pursuing my dreams.
Someone could show a scientist, and then they could figure out a cure and keep on experimenting.
Although I have NF and I went through my own struggles, the second I found out my son had it, my entire world changed. And it was my mission from then forward to find a cure or an effective treatment.
The more attention there is to it, the more research, the greater chance they're going to find a cure.
We want everyone to support her and support everyone dealing with NF. And the way we've felt so supported by the CTF community and the NF community.
My name is Jesse. I want you to see me and see NF.
My name is CJ. I want you to see me and see NF.
Good morning, everybody, and thank you for being here. I know that this is going to be a smaller crowd throughout the entire event, and I just want to welcome and acknowledge that you're here and there's community to be found here, and I hope that you get a lot out of your time. What's happening? I'm just gonna wait. Oh yeah, sure. Yeah, let me know if they start showing up. Anything yet? No, not yet. Sorry, guys. Keep talking, testing. There we go. There we go. Okay, I apologize. Thank you for your patience. Thank you for being here, and thank you for your willingness to continue to advocate and put up with some of these kinds of issues. I want you to know that we're really happy that this community is here. I've personally seen the attendance from our NF2-related schwannomatosis and schwannomatosis community grow at this event, and we hope that we will continue to earn your trust and as you continue to be a part of CTF's community. So I just have a few housekeeping, and then I'm very excited to welcome our first speakers for the morning. So please know that in the Whova app that you should have on your phone, you can ask questions in that app if you're more comfortable with that. And we have a staffer in the room who can go into that app at the end when we have a question and answer and ask those questions. So please feel free to use the app if you would like to. We'll also take questions in the room, so that's also fine. In all of our rooms, especially in East, I know this was an issue last night, we have reserved tables at the front of the room if you really need to make sure you have access to seeing those captions. So please find me if you are not able to get one of those seats or if you're not sure where to go. We want to make sure that you guys can see everything that you need to see and want to, be able to fully participate. Okay, so having said that, I'm really excited to welcome our speakers, Dr. Friedman and Dr. Schwartz. Have worked together for a long time, and I know they have a lot of really great stuff to talk about this morning. They're going to kind of tag team it and go back and forth a little bit. So with that, please welcome Dr. Friedman and Dr. Schwartz.
Alrighty. I'm going to try to be on the side of the podium, which is a very strange place. So I'm Marc Schwartz, and I'm here with Rick Friedman, who's my partner in surgery for all of this. I'll wait for the slides to be queued. We're going to go back and forth as was introduced. So the topic is hearing preservation and rehabilitation in the surgical management of acoustic neuroma in NF2. And this is not a comprehensive talk. So this is basically a survey of the things that we can do surgically for acoustic neuromas with hearing as a goal. As a background, obviously, this is different than a typical, let's say, neurosurgical group that I talk to. I'm sure a lot of this is going to be familiar to you. As a background, though, I'm thinking as basically an acoustic neuroma surgeon, what's important to understand with NF2, that these are not exactly the same kind of tumors. So when we see somebody with a sporadic acoustic neuroma, it's one mutation, or it's two hits, but it's one cell that has a mutation and you grow one tumor. But in many cases of NF2, we're talking potentially about polyclonal tumors. So several different sites of an origination of a tumor. And that makes things a little different when we handle them with treatment, with surgery. Frankly, I'm not talking about radiation, but with radiation also. You all understand that there's a first hit that's a germline or mosaic in many cells in the body, but that second hit on the second gene can be different from one tumor to another. And so we sometimes think of NF2 tumors as being more like bunches of grapes as opposed to an apple, which adds some complexity to their treatment. So nerves can actually go between different clones and can go in through the middle of the tumor bulk. My experience actually is that they're not just grapes. It can also be like kind of onions. So instead of seeing just bunches, we see sort of tumors growing inside of other tumors. We can see different planes, different places there's nerve fibers. That's largely because not all these clones grow at the same speed. Some of them grow more rapidly than others. This is Jessica Schulte, who's the neuro-oncologist we work with at UCSD, who has a particular interest in NF and NF2 and NF1, both clinically and also research-wise, trying to get to the bottom of why that is. Why do some tumors grow more rapidly than others? From that initial mutation, we can predict the number of tumors that a patient has, but not so much the rate of growth of the tumors. Again, different treatment options. There's surgery, there's radiation, there's medical treatments like with Avastin, there's observation. But really, we're going to be talking about surgery here. It's too controversial and too big a topic to talk about everything. I just want to give an idea of the different things we can do. And so there's really 5 topics in 2 categories. And one of which is hearing preservation, and that's the first 3 topics. What can we do to try to preserve hearing surgically? And then the last 2 are what can we do to rehabilitate hearing surgically? And we're going to go back and forth I'll go back and forth with Dr. Friedman about these different topics based upon the issues. 2 or 3 of these are bigger topics, and I'll tell you that 2 of them are very small topics, and I'll sort of hit those. Also, I'm going to talk about sort of data versus what does data lead to in terms of science, what are our own observations and our own experiences, which is kind of very different than recommendations. I understand that any recommendations for any patient are based upon those things, but there's individualization, so we have to look at the specific characteristics of any one patient. And what applies to one patient may not apply to another. And also, recommendations are, what are our recommendations? There may be multiple options for any patient, and it's a matter of, in an imperfect world where we don't know exactly what's best, to sort of come to the best treatment option amongst many. So for hearing preservation, first thing I'll talk about is what we call middle fossa craniotomy for tumor decompression. This is not tumor resection. And when we see this is when we have a patient, especially with an only hearing ear, and a tumor that's, we say it's not ideal for treatment for resection or other treatments, and usually with rapidly declining hearing, can we do something to prevent that hearing from continuing to rapidly decline? It's not removing tumor, so there's going to be additional treatment needed in the future. And it's inevitable what's going to happen if we just decompress, but can we slow down the rate of hearing loss? The anatomy is complex, and obviously we're operating in the inner ear and the associated nerve and brain structures. And for a middle fossa craniotomy, we're going above the ear, below the temporal bone, to get past the cochlea and past the balance canals to get to where the tumor grows in the canal generally, or in the next to the brain next to that. Incision looks like this. We put a retractor in to elevate the temporal lobe. Now this is on the outside of the lining, so there's a lining in the inside of the skull. We stay on the outside of that the whole time, and the brain tolerates that very well. And we can see the bone on the bottom of the skull base. It looks kind of like this. I mean, this is a very indistinct picture because we're actually looking at just flat bone, but trying to figure out how to go between the balance canals and the cochlea around the facial nerve to get to where the tumor is, and to totally decompress things, to take all that bone away. Does this work? I mean, yes. Remembering that these are patients that typically have rapid hearing loss going on. And after surgery, hearing can be a little bit better, although we usually don't get big advantages. I don't have to put up the whole AAO-HNS scale here. I'm sure everybody's familiar with it. Over time, hearing does get worse, but at a much slower rate than was happening before the decompression. Okay. There's a couple other papers from France showing some hearing maintained longer than you would expect without having done the decompression. So we can slow it, but we don't change the process of the disease otherwise. Does not make it unnecessary to do other treatment in the future. And the one thing I'll say for sure that making this a very short talk is since we've had Avastin and other treatments to manage these sorts of situations, we're doing this much less than we used to. So this is kind of a rare thing we do these days, although occasionally we see a patient where this is a good option. Other things haven't worked, but we're really doing this very rarely compared to how much we've done it in the past. Rick? Next we're going to do the removing the tumor from middle fossa and what the role is for that.
Good, I don't get the music. I can do the dance. Let's see. Okay. So the middle fossa is an approach to removing tumors that are small in suitable patients. Suitable patients really depends on medical condition, whether the patient is appropriate for surgery. The position of the tumor is somewhat predictable or predictive, but as Dr. Schwartz said, often there are multiple tumors in the internal auditory canal. One of my mentors, Dr. Brackman, we wrote a paper together about early proactive management of NF2, which is, I don't know if it's it might be a controversial topic. The issue is there aren't a lot of places in the world that do middle fossa. So if there's one thing I can accomplish here is not getting patients necessarily to come to San Diego, but making you all aware and through your awareness, making other people aware that there are centers in the country that don't do this and should refer or at least offer a second opinion, always. So the middle fossa is a very powerful approach for saving hearing with small tumors. We do it for patients who have sporadic acoustic neuroma, and we do it for patients with NF2. We've had a series of children since we've been in San Diego, and I'm pretty sure all but 2 we were able to save their hearing. So for me, that is it's a very emotional moment, but it's a very special time in my career to do something like that for someone, something that we've worked so hard to master. The benefit of the middle fossa is its great exposure for tumors that even go up against the base of the cochlea. It's used for growing tumors in the internal canal or for those with extension outside of the internal canal. Results do depend on the configuration of the tumor with regard to the cranial nerves. There is some evidence to suggest that if the tumor doesn't fill the canal completely, that our ability to save hearing is better. Marc thinks, other than for hearing preservation, it's inferior to the TransLab. I'm not so sure. I think for small tumors, the issue is, and everybody in this room knows that, is the facial nerve outcomes. We don't want to paralyze anyone's face. And I'm happy to say that facial paralysis, with Marc, I don't have a single patient out in the world in 20 years that is living with a facial paralysis. About 4% are living with some weakness, but overall 95% have normal facial function. This is the approach and probably why not many people do it. There aren't a lot of landmarks, and I was blessed to work with 2 surgeons that really, well, Bill Hitzelberger in particular, who brought this approach into the real world and trained some of us to do it. And it's a procedure that you only do if you're able to do it a lot, and not a lot of centers are able to do it a lot. Dr. Schwartz and I, we take care of about over 400 acoustic neuroma patients per year, and we operate on about 170 of those. So we have a large volume and feel very comfortable doing this. It requires exposure of all the nerves of the internal auditory canal, and then I usually do the exposure, and then Dr. Schwartz will come in and do the tumor resection. This is showing tumor out, facial nerve in the normal position, and then down low here is the cochlear nerve, which is under the facial nerve, and we do everything in our power to preserve that. I'm working with a group of neuromonitoring people to look at the possibility of better intraoperative imaging that could help us delineate the tumor from the cochlear nerve a little bit better and the tumor from the artery. The issue with this is the inner ear has one little artery, and it's often not visible. So we monitor hearing during surgery. We can monitor hearing even though patients are asleep. And we take our time, very slowly, and looking out for any vessels that may be critical to hearing, but oftentimes we can't see them. So I would say overall, for the appropriate size tumor that's confined to the internal auditory canal, our hearing preservation rates are close to 70%. This is the paper I was talking to you about, early proactive management. The upside is tumor burden is reduced because we take tumors out. The upside is the possibility of saving hearing, which is far more likely than not. The downside is the potential for losing hearing on that day. Now, let's see where we're going here. Yeah, this is just more hearing preservation. Looks like, say again? Yeah, it's old data, but the hearing preservation rates are quite good. What has come, and we'll talk about this in a minute, but what has become, I wouldn't say popular, because that would imply that there's a large patient population, but the one decent thing that we have now, if we, let's say a patient comes in for a middle fossa and we're unsuccessful. We're successful at removing the tumor, but we're unsuccessful at preserving hearing. Oftentimes it's because of the little vessel, and the auditory nerve is still intact. So we can put in a cochlear implant after something like that, after a case like that, and we'll talk about that a little bit. Auditory brainstem implants are the mainstay of auditory rehabilitation for deafened patients. Aside from Matt and a few other patients, open set speech is meaningful speech understanding visually is not achieved a lot in auditory brainstem implant. We do have some patients in the world who do really well. But cochlear implants provide overall better word understanding and overall better quality of hearing. So my point in this is we're always nervous going in on a middle fossa for parents who want us to try to save their children's hearing. Thank God more often than not we're successful, but when we're not, there is the option for cochlear implant, and we'll talk about that too. Are you up next, Marc? All right, cue the music.
All right, so again, I mean, this is just a summary of that. Again, I don't think our goal is to try to get everybody to come to San Diego for surgery in this situation. When we have a patient who's referred or we're considering surgery on, we spend a lot of time poring over the MRIs in detail, trying to think, what about this? It has to be a small tumor, a small tumor, looking at the actual specifics of exactly what the configuration of the tumor is, how favorable do we think it is. If we think it looks pretty favorable, then we're going to be want to be more proactive, but other cases we look at them and say this is unfavorable, and it's a real kind of gestalt. It's not something that I can discuss all the details here. It's just our experience allowing us to do that. And also to be clear, a lot of these tumors, some set of these tumors do either recur or come back in the NF2 setting, unlike the sporadic. And the goal is to preserve hearing for as long as possible, once again. This is going to be a very short section. So just retrosigmoid is another way that we do occlusal neuroma surgery, which is next to the cerebellum. The advantage is we can approach larger tumors. We don't do it very much for hearing preservation because we don't think that we can be very successful. And again, other than hearing preservation, we think that the translabyrinthine is a better approach. We go behind the ear. This is a big vein that we call the sigmoid sinus that we have to stay behind. That's why we call it retrosigmoid. And we go next to the cerebellum to get to the tumor. And we come down next to the cerebellum, and this time on the inside of the lining of the brain, so you can actually see the folds in the cerebellum to see the tumor. Usually take the center of the tumor out. These are larger tumors before taking the surface and taking it off the nerves. And even in patients without an NF2, for these tumors as they get larger and larger, hearing preservation is a very difficult goal. What is it in NF2? I mean, we do not have any publications for this because we don't really do this very often. We don't think that it works very well. I found one publication from Germany, and this is from Professor Tadagiba, who there's a kind of a big heritage of these cases in Germany, and he's now the active guy doing most of these operations. He's an excellent surgeon. And he published a series. And when you look at the results, they look quite good. I mean, preserving hearing in most patients, 26 out of 32 or something like that. That's a very high number. But when you look and see what they do, these are mostly all partial resections. There's very few of them are total resections, or even near total or leaving small pieces. It's all decompressions of the tumor. And if you look at the tumor volumes before and after surgery, this is the volume of the tumor. He does surgery going from and takes 2 centimeter tumor volume. This is volume, not diameter, and makes them 1 centimeter tumor volume. Now you can't see it doesn't project very well, but at the top of this is the formula for converting volume to diameter. And basically what's happening is, assuming these are spheres, these tumors, taking a 1.5 centimeter tumor and moving it down to about a 1.25 centimeter tumor. So yes, if you go in and take part of the tumor out, you can preserve hearing, but I'm not sure what the long-term goal of that is. Sometimes we see crazy things and other ways that people are doing things. So retrolabyrinthine is a different approach. We don't understand exactly what they're doing here, but I just wanted to present that people are doing different things. So again, for decompression, in certain cases, there may be select uses for this, but this is not something that we would typically do. And I think you have to be very, very not aggressive with hearing as a goal. Again, I think largely because these tumors are not just one apple. They can have nerve fibers going between different parts of the tumor, and it becomes very, very, very difficult to follow the course of the cochlear nerve in these situations. Now switching gears to hearing rehabilitation, there's sort of two topics here. And how do we rehabilitate hearing? So somebody who has lost the ability to hear, how do we rehabilitate hearing? So this is not preserving hearing anymore. Obviously there's hearing aids, which are useful for people that have partial hearing. The first thing we think about for most patients who've gone deaf is a cochlear implant. But obviously if the cochlea itself or the cochlear nerve is not intact and the cochlea is not connected to the brain, that's not going to work. So that's when we get to auditory brainstem implants. And I'll talk about auditory brainstem implants, and Dr. Friedman will come back and talk about cochlear implants. So the goal is restoring auditory function when there's no cochlear nerve. We think that the best time to do that is the same time as taking tumor out. Because when we take a tumor out, we're looking at exactly the right place where this goes. So we can do it kind of as an add-on to surgery, not as a whole big operation down against the brain. This is a typical case, and then this is the back of the brainstem, where we're going to be placing the brainstem implant right over the next step in line on the hearing system after the cochlear nerve, which is we call it the cochlear nucleus complex, and it's on the surface of the brain, but kind of in the inside, where the fluid flows. So we have to find that location. And this is what it looks like on an MRI. We go down, tumors will be in this area, and the cochlear nucleus is sort of right up in this hole that goes between the outside and the inside where the fluid flows. This is what they look like. They look the same as a cochlear implant, basically. And we have an array of electrodes that's designed for this and sort of developed over time from the first case a long time ago. And since about the last 24 years, there's two versions of this, only one of which is widely available in the United States. And this is the electrode array for the Cochlear Corporation device. There's also a MED-EL device, which is used more often in Europe, although a little bit here. 21 electrodes on the right side there. We do these typically from a translabyrinthine approach. And this is working just behind the ear. You can see that this is the right side again. We go through the mastoid, which is the big bone with the air spaces behind the ear, down and see the balance canals. Remember I showed you the sigmoid sinus before, that which was in front of the retrosigmoid. We're now working in front of the sigmoid sinus, which is a big vein right here. Take tumor out. We're looking down at the nerves. And right deep to where the tumor is, the electrode array can go against the brain over here. I don't expect you to understand this, but this is sort of what it looks like to the surgeon under the microscope. Foramen Ilushka is that hole where the fluid flows, and that's where we place this, right behind where the eighth nerve was and right on top of where the lower cranial nerves were. This is a cochlear implant with an array, with the electrode array designed to coil in the cochlea, but the ABI looks exactly the same. One issue that we deal with NF2 and patients who need a lot of MRIs is that these have magnets internal to them, and that makes MRIs difficult. So typically, we take out the magnet and put a non-magnetic disc. That then it's a little bit of a pain in the ass because you have to glue a disc to the scalp. But for somebody who's going to need lots of MRIs, that's really necessary. There are now cochlear implants that are MRI compatible, but the ABI has not yet been advanced to that through the FDA process. Plus, if you have magnet in it, so it kind of makes the MRI much more difficult to interpret. It creates a very large artifact, which is another problem. What are the results? So how do we measure results? Typically, in most patients, looking back historically, we don't see a lot of what we call open set speech discrimination. So this is not giving, on average, super great results, anything like normal hearing. And so we measure ability to hear sounds and speech. And we have what we call closed set tests, and we have open set tests. So a closed set test is you hear a sound or a syllable and have a multiple choice question as to what it was. And then open set is without that multiple choice. What did you just hear? And sentences are generally easier than single words. So again, from the original data that was going back decades, not much open set, a little bit on average, but that's average. But for the closed set, and this is with speech alone, no vision, significant improvements compared to random. So random is these lines, but what does the average patient do? A lot better. Not perfect, and this is a limited, but a lot better than having nothing. It's also useful for augmenting lip reading. So if we add the process, the auditory response from the ABI to ability to lip read, we see a pretty big improvement on average in terms of communication. I think most importantly, the one on the right side here, showing that the sentence understanding with lip reading is much better than without the ABI. But it's very variable. So we see a huge range of response from people who don't do very well to people who do very well. And I wish I could tell you ahead of time who was going to be the good responder, but it's kind of hard to tell that. And there are a few patients, and again, this is the older data, there are a few patients, and it's a minority, but there are a few patients who do very well and have some significant, even open set, sound alone understanding of speech. Another principle is we put this in, it gets activated a few weeks later, and people tend to hear jumbles at first. But the more you use it and over time, and the more you get used to it, the better and better patients do. And I will tell you that I think it's not just using it over time, but it's also kind of mindfully using it over time and really working and getting the best function possible. It's like learning and potentially hard work to do this. There are some other reports from other places, and again, this is Germany, showing similar results, if not more recently. I think it's also more recent, a little bit better results than we saw historically. This is generally using the Med-El device as opposed to the cochlear device, but we don't have any reason to think one is really better engineering-wise than the other. When we ask patients, do they like the devices? The answers are yes, I like having this. I use it a lot, and it helps in my daily life. Most patients respond that way. This is our more recent data. So since arriving at UCSD, this is not yet published as a paper, but it's been presented at a meeting. This is 11 patients, no surgical complications. Now 9 of 11 got some useful response, so it's not 100%. 5 of 7 showed speech recognition to some degree with just sound. And of these 11 patients, we actually have one with excellent sort of cochlear implant-like understanding, so about a 10% chance. This patient can actually use a telephone. And subsequent to this, there's a second patient that's like that also that we have. Why is it hard? I mean, first off, the brain is distorted. It's different in every patient. We've got to put it on the brain and sort of hope that we're in exactly the right place. And also, this is work from a guy called Stefan Rosal in Germany. Again, this is the target on the brainstem, showing that individuals and this is not NF2 patients, it's just dissecting cadavers, that there's a very large amount of individual variability of where exactly the target is. And it's not something that we can tell from MRIs or anything like that ahead of time. So just one person's anatomy may be more favorable than another person's anatomy. And that includes also the distance to the surface of the brain. Again, just showing different things that people are doing. This is a paper from China doing awake surgery to monitor in surgery for placement of ABI, which is, I think neither one of us can imagine. I think neither one of us can imagine doing that. In summary, ABI provides useful auditory stimulation to most patients. Results are variable, with some patients doing very well, but not everybody. Function improves over time, and as I said, mindful use and really practicing is important. You have to be tuned up all the time, so it's not just go home and use it. You have to come back and talk with the audiologist and have things optimized on a regular basis, so it's an ongoing process. Most patients are daily users. And then the last thing is what we call a sleeper. So somebody is having surgery for an NF2-related acoustic neuroma on the first side, have to have the surgery. The best time to put that ABI in is at the same time as surgery. Even though there's still good hearing on the other side, we'll often recommend putting an ABI in on the first side. It's not going to be useful when the other side still hears. But we don't have 100% success, and we want to do the best thing possible and have the best possible options and results. Another thing is better results with experienced surgeons. So I don't think you can go to a surgeon who's never done one and expect good results on their first or second or third case. And frankly, again, just like before with the Avastin, I think the numbers of cases we've has gone down, not up. We're delaying things longer and longer, and not getting to this point as quickly as we did before. But in select patients, this is a really good option. Personally, I think that in nearly all cases when somebody's having surgery for an NF2-related acoustic neuroma, with the idea that there's going to need to be loss of hearing on both sides, I think this should be really considered with every single case. You're up again.
I'm just going to go through this quickly because I want to save time for questions if you have them. Basically, you need an open cochlea and a cochlear nerve to stimulate with a cochlear implant. So the reason the auditory brainstem implant is useful, especially for patients with NF2 and larger tumors, is often the cochlear nerve can't be preserved. But when we're dealing with smaller tumors, we can often preserve the cochlear nerve and put in a cochlear implant. And as I said, the speech recognition is, in general, greater with a cochlear implant. The goal is restoration of auditory function when there's a viable nerve. Smaller procedure than an ABI. We can do it as an outpatient. It takes about an hour. Can be used in patients with NF2 that are being observed. So we can put an implant in an ear that's deafened that has not had the tumor removed. And then obvious concern about durability. Overall, I think the outcomes are not quite as good when we're putting them in an ear that has a tumor, but again, it's still useful and probably overall, on average, better than an auditory brainstem implant. These are just papers. This is from the Mayo Clinic showing the variability or the variables of auditory performance. But in general, patients with cochlear implants do well. I don't think, here we see ABI versus cochlear implant, and you can see that the performance overall is generally significantly better with a cochlear implant. Again, we have outliers. We have an outlier here in the audience, but overall, cochlear implant functionality is better. And I don't know that I need to go through all of these. I think at this point, we only have 9 minutes left, I guess. So let's open it up for questions. I hope you've gotten a sense of what the options are to preserve hearing and to restore hearing. And so now we'll open it up for questions. Yes?
Hi. My question is about the ABIs and cochlear implants. I'm a nurse coordinator, so I do have to often help patients who have these implants with getting their MRIs. It's a big headache, so thank you for acknowledging that. But I'm wondering, what is the long-term retention of those devices? How often are patients still actually using their devices several years later? I heard you say, yes, they need a lot of upkeep, tuning, and in some of my patients, I've noticed that they've stopped using their devices. So I have someone with an ABI, he's taken the magnet out.
Yeah.
I have several people with cochlear implants, they don't use them, they've turned them off. And I'm wondering, in your experience, what's like maybe the 5-year retention? How many people are still using their devices several years later?
I would say because of the variability and function of the auditory brainstem implant, and again, I want to reiterate that it's important to have it placed at a center that has a lot of experience. But if they're not working very well, I find that patients don't use them. So it just depends on the functionality. As far as mechanically and technically, we haven't had much of a problem. The failure rates are very small.
I would say it also depends on the specifics of the individual person and their disease. So if we have somebody who has small tumors, are not growing, they're not progressing, things will be maintained a long period of time. And if we have some patients that just have recurrent tumor after recurrent tumor, that makes things more difficult. And that, frankly, I think that the retention of the data is showing that the retention of the ABI, is, if it's working well, is better than the retention of the cochlear implant. Because the cochlear implant depends on the nerve being okay.
Yeah.
But that's not all patients. I mean, there's certain patients who the cochlear implant's going to be great for a long period of time.
Yeah, one of my best cochlear implant performers was an NF2 patient.
All right, I have a question here from the audience. I have an ABI which is not working. What are the options that I have? It never worked after her surgery.
Historically, only about 90% work. So it didn't work from the beginning. It may just be a situation of being in that 10%, and that's sort of why we like to try both sides if we have that opportunity. If it worked and stopped working, it may be worth. It didn't work at all, but it may be worth just reassessing and making sure there's no response whatsoever with a experienced audiologist who does these sorts of things.
And yeah, I think the option would be the opposite side.
Yeah.
Either another ABI or a cochlear implant if it's possible.
But I don't think any of us would recommend going back in and trying to reposition it because it's going to be all scarred in and very, very difficult.
We did have a question in the app as well about whether or not the slides would be available after the event. The slides will not, however, we are doing recordings of all of the sessions, and those will be available, and we'll message that through the Whova app, as well as have links to them through other communications with CTF.
Hi. So my ABI was actually activated a month ago, and I was just kind of curious for timeline of like when you would see that to stop being considered a sleeper. I have found it to be very useful with lip reading and further development of just hearing the rhythms and the syllables, and I've been finding it very successful to have, and also saw your statistic of the person who was successful for hearing and was wondering if they were a sleeper and where was that situation?
So if your hearing is good on the other side, then it's a sleeper. But even as a sleeper, I mean, the more you use it, the better I think the better, I can't guarantee anything, but the better your long-term outcome is going to be. And I really think it's that kind of mindful use. I mean, it's saying, I'm going to do everything I possibly can to make this function as good as possible.
Hi, sorry, I have a two-part question. My first question is, have you ever had an implant move?
Move.
Yeah, post-op.
An auditory brainstem or a cochlear?
Yeah.
ABI. I mean, I don't know if I personally have with Marc, but I've seen MRI scans.
Yeah.
I've seen MRI scans of them moving out of the lateral recess.
So it's a difficult question because it's kind of hard to image exactly where it is. So the CAT scan shows the device really well, but it doesn't show the brain very well, and the MRI shows the brain really well, but not the device really well. So the question is, did it actually move on an MRI, or did it move on the imaging, or did it move based upon where the surgeon thought it was? Yes, we see some weird things here and again. The longer you've done this, the more you realize you see things you didn't expect, and not everything can be explained. I have seen cases where a tumor has come back. There's been recurrent tumor, a new tumor that's changed the orientation between.
Sorry, I know it's a hard question. My second question is, if you perform a debulking and then you have to perform another one in a patient, let's say 5 years later, and would you have to take out the implant?
No, not necessarily. It depends on the specifics, but not necessarily. I think we do everything possible to maintain the implant. These are very delicate devices, and going back and doing the whole approach, I think there's a risk of breaking it.
Yeah.
And I think we'd expect potentially the function to change afterwards, and maybe have to start over again.
Yeah, there's often a lot of scar tissue, not only at the brainstem, but in the mastoid. And so it's often hard to get back in and preserve the electrode, either integrity or position. It's tough.
Okay, that was just curious. I mean.
We have another question from the app. Do you have clinics or doctors you recommend for vestibular schwannoma surgery in other parts of the country?
That's a tough one for me. San Diego only. I think.
I actually had brain surgery at NF2-SWN in South Carolina.
Yeah.
I don't have NF2. Oh, sorry. I have schwannomatosis. I don't have NF2, but I had a schwannoma on my left trigeminal nerve, and it was a dot, and then it blew up, and it was pushed on my brainstem.
Yeah.
So I see Dr. Plotkin, but I had surgery at MUSC, the Medical College of South Carolina, and my brain surgeon was Dr. Vandergrift. Alex Vandergrift's his name, and he pretty much saved my life. And he does brain surgeries all the time. I'm not sure if he's done NF2 surgeries, but he's pretty amazing.
Yeah.
So I think you have to go to there are a few centers in the country that have enough volume and provide complete care, okay? As we've alluded to here, there are 3 different approaches to removing acoustic neuroma, and the centers should be facile in all 3 approaches. The centers should have dedicated neuro-oncology, dedicated neurology. There are a few centers in the country. There aren't a huge number.
Yeah.
NYU does some of this work. Mass General does some of the work. UCLA?
Yeah.
Yeah. I mean, they've sort of partnered with House.
Recently, yeah.
Yeah.
Unfortunately, we're out of time. So if you do have further questions, I'm sure that we can get those addressed for you. With our speakers, you can continue to add questions in the app, and we can make sure that you get answers for those questions. Thank you so much.
Thank you.